9 things every senior on amlodipine, losartan, or lisinopril needs to understand. A cardiologist's honest conversation. I want to tell you about a patient I will call Arthur, 76 years old, retired school principal, the kind of person who tracked everything, his appointments, his doses, his readings. 14 months on amlodipine without a single missed dose. His wife called me on a Tuesday afternoon, her voice carrying the specific flatness of someone who has been worried for long enough that the worry has become exhaustion. He had stopped going to church. His ankles, she said she did not recognize his ankles anymore. Arthur had not had a heart attack. He had not had a stroke. He had been sitting with swollen ankles for 3 months, convinced his heart was failing, skipping doses on the days he needed to walk because he was ashamed of what his legs looked like. That silence, that gap between what was happening in his body and what he understood about it, nearly cost him everything. I have been in cardiology for over 3 decades, and the conversation I'm about to have with you is the one that a 12-minute clinical appointment almost never has time for, not because physicians are withholding anything, because 12 minutes is structurally insufficient to explain something that genuinely deserves much longer. These are the 9 things every senior taking amlodipine, losartan, or lisinopril needs to understand. The 9th is the most important. Stay with me. 1. These 3 medications are not the same, and that distinction matters. Amlodipine, losartan, and lisinopril all lower blood pressure, but they do it through completely different biological systems. Those different systems produce completely different side effects and completely different warning signs. If you do not understand which system your medication is working on, you will misread what your body is telling you. Amlodipine, the calcium channel blocker. The smooth muscle surrounding your artery walls contracts in response to one primary trigger, calcium entering the muscle cell. When calcium flows in, the artery narrows and blood pressure rises. Amlodipine reduces how many calcium entry channels are open at any given time. Less calcium entry, less arterial constriction, lower pressure. What it does not do is address why those vessels became chronically tight in the first place. It manages the output of a system, the downstream consequence, without modifying the upstream cause. This distinction has significant implications for how you think about your treatment. Lisinopril, the ACE inhibitor. Your body produces a molecule called angiotensin II, a potent vasoconstrictor that simultaneously signals the kidneys to retain more fluid, both of which raise blood pressure. To produce angiotensin II, the body requires an enzyme called ACE, angiotensin converting enzyme. Lisinopril blocks that enzyme. No enzyme activity, no angiotensin II production, lower pressure. Because this mechanism also reduces the workload on the kidneys by decreasing the fluid retention signal, lisinopril is frequently the preferred choice for seniors managing both elevated blood pressure and early signs of renal impairment. One drug operating through 2 protective pathways simultaneously. Losartan, the ARB or angiotensin receptor blocker. Losartan works on the same biological system as lisinopril, but at a different intervention point. Lisinopril prevents angiotensin II from being manufactured. Losartan allows angiotensin II to be produced, but blocks the receptor it needs to bind to in order to produce its constricting effect. The signal is sent, the door is locked, the downstream consequence never occurs. The clinically important difference between these 2 drugs, lisinopril produces a dry, persistent cough in a meaningful percentage of patients through a mechanism involving bradykinin accumulation. Losartan does not. Physicians switch patients between these 2 drugs not because one is more effective, but because a cough at 2 in the morning every night is not something any senior should tolerate when an equivalent alternative exists without that side effect. 2. The amlodipine ankle swelling, what it actually means. This is the conversation Arthur should have had before he ever stopped going to church. Amlodipine relaxes the smooth muscle in the small arteries of the lower extremities more effectively than it relaxes the smooth muscle in the small veins. The consequence of this asymmetry is a pressure differential. Blood flows into the lower limb readily through the relaxed arteries, but encounters relatively greater resistance flowing back out through the less relaxed veins. The net result is fluid shifting out of the vascular compartment and into the surrounding tissue, particularly in the ankles and feet. This is why your shoes fit in the morning and feel tight by 6 in the evening. This is why the swelling resolves overnight when you are horizontal and returns by the end of the following day. The gravitational component is real and predictable. It is not heart failure. It is not kidney disease. It is a mechanically predictable consequence of how this specific drug acts on the vascular physiology of the lower limbs. What made Arthur's situation dangerous was not the swelling, it was the silence. He began skipping doses to manage the embarrassment, and his blood pressure climbed without his awareness for 3 months. Report ankle swelling to your physician. Do not conceal it. Do not manage it by skipping doses. Skipping antihypertensive medication is considerably more dangerous than any peripheral edema you have been living with. 3. The lisinopril cough and the warning sign that cannot wait. If you are taking lisinopril, I want to ask you a direct question. Have you developed a cough since beginning this medication? Not a productive cough, not something associated with illness. A dry, scratchy, persistent tickle that nothing clears. A cough that is simply present. The critical clinical detail that most patients are never told: the lisinopril cough does not always begin immediately. It can emerge weeks or months after starting the medication. By the time it appears, most patients have entirely stopped associating it with their prescription. They attribute it to seasonal allergies, acid reflux, dry indoor air. They purchase lozenges. They change their laundry detergent. The answer has been sitting in their pill organizer every morning. A woman I will call Patricia, 69 years old, 4 months on lisinopril, developed a throat tickle that cost her months of sleep and considerable anxiety before anyone asked the right question. Nobody had told her that an ACE inhibitor cough can present late. A single question during an appointment resolved what months of misattribution had not. A dry cough from lisinopril is uncomfortable. It is not dangerous. It warrants reporting. There is a straightforward solution. Switching to Losartan eliminates the cough in virtually all cases. There is one symptom that is in a different category entirely: swelling of the lips, tongue, face, or throat, particularly if accompanied by any difficulty breathing or swallowing. This is angioedema. ACE inhibitors can produce this reaction, and it can escalate to life-threatening airway compromise within minutes. This is emergency care immediately, not a call to the office, not a wait and see. Immediately. Dry cough. Report it at your next appointment. Throat or facial swelling, emergency care now. 4. The potassium risk. It is in your kitchen, not your medicine cabinet. For seniors taking Losartan or lisinopril, one of the most consequential risks is not in the pharmacy. It is on the kitchen counter. Both medications work, in part, by reducing aldosterone signaling, the hormonal pathway that tells the kidneys to excrete potassium. The result is that potassium is retained at higher levels than it would be without the medication. When serum potassium rises too high at a condition called hyperkalemia, it disrupts the electrical conduction system of the heart. The symptoms can be subtle: muscle weakness, occasional cramping, a sense of irregular heartbeat. Sometimes there are no symptoms at all until the situation becomes serious. The specific products that quietly compound this risk: salt substitutes marketed as heart healthy that replace sodium chloride with potassium chloride, electrolyte replacement powders, senior nutrition drinks. Each of these adds potassium to a body whose medication is already promoting its retention. A patient I will call Bernard, 74 years old on Losartan, made the thoughtful decision to switch to a potassium-based salt substitute because he believed he was reducing his cardiovascular risk. He was right that excess sodium is problematic. The gap was that nobody had told him his medication was already retaining potassium, and the combination produced dangerously elevated levels before anyone connected the dots. Bernard was not careless. He was acting on incomplete information. Read every label on every heart-healthy product in your kitchen. Ask your physician directly, given my current medication, is a potassium-based salt substitute safe for me to use? That is a specific, answerable question that can prevent a serious problem. 5. The pain reliever in your bathroom cabinet. At the conclusion of this video, I want you to go to your bathroom cabinet and look for ibuprofen or naproxen. If you are taking lisinopril or losartan, particularly if you are also on a diuretic, regular use of nonsteroidal anti-inflammatory medications creates a specific risk to kidney function. Each of these medications individually has a manageable renal effect. In combination, particularly in a body that is even mildly volume depleted, they can create conditions that the kidneys struggle to sustain. The reason this goes undiscussed is that ibuprofen does not register as a real medication to most people. It came from a shelf. It does not require a prescription. It never gets mentioned during appointments because it never occurs to the patient to mention it. Ask your pharmacist this specific question. Is regular ibuprofen use safe given all of the medications I am currently taking? That conversation costs nothing and may prevent a kidney injury that nobody saw coming because nobody thought to ask. 6. What illness does to your medication? If you are taking Losartan or Lisinopril and you become acutely ill, vomiting, diarrhea, heavy sweating, and inability to maintain fluid intake, the medication that functioned appropriately yesterday may behave very differently today. These medications were calibrated to a body with stable fluid and electrolyte balance. When illness disrupts that balance, the same dose can produce blood pressure reduction that is excessive for a volume-depleted body and can impose a stress on the kidneys that stable conditions would not. A patient I will call Gerald, 78 years old, 13 months without a missed dose, developed a gastrointestinal illness and maintained his medication schedule throughout because his compliance was a source of legitimate pride. That evening he stood up and nearly lost consciousness. His blood pressure had dropped further than his depleted body could compensate for. The medication had not changed. The body it was working inside had changed completely. Write this instruction and place it somewhere you will see it when you are unwell. If I cannot maintain adequate fluid intake, I call my physician before taking my blood pressure medication. This is not a reason to stop the medication independently. It is a reason to communicate with your physician before the next dose. 7. The most dangerous blood pressure. Reading is not the highest one. The most clinically consequential blood pressure reading is not the highest number you have ever recorded. It is the reading taken at the wrong moment under the wrong conditions and used as the basis for a decision. Blood pressure is not a fixed biological constant. It fluctuates continuously in response to sleep, stress, caffeine, posture, ambient temperature, recent physical activity, and, critically, the anxiety generated by the act of measuring it. A single reading taken in a state of health anxiety will not reflect the same physiological reality as a reading taken after 5 minutes of seated rest under consistent conditions. A patient I will call Diane, 67 years old, convinced her lisinopril had stopped working, had accumulated pages of blood pressure readings taken at every moment of anxiety. The numbers appeared chaotic and alarming. When we standardized her measurement protocol, same time, same arm, same seated position, 5 minutes of genuine rest before measurement, a completely different picture emerged. Her medication was working. The apparent chaos was in the measurement methodology, not the medicine. Measure at the same time each day. Use the same arm in every session. Rest in a seated position for at least 5 minutes before measuring. React to patterns across multiple days, not to individual readings. A single reading is noise. A pattern across consistent measurements is information. Only information justifies a clinical decision. 8. The hidden environment your medication works inside. I have seen this across 3 decades of clinical practice. 2 patients of the same age, the same diagnosis, the same medication at the same dose, with completely different outcomes. The medication is identical. The biological environment it is working inside is not. Elevated dietary sodium requires your medication to work harder simply to hold the same ground, because sodium drives fluid retention and vascular pressure independent of the medication's mechanism. Poor sleep elevates stress hormones that promote the arterial constriction your medication is simultaneously attempting to reduce. Excess body weight adds cardiovascular pressure load that no single medication fully compensates for. Sedentary behavior allows arterial stiffness to progress through mechanisms the medication does not address. When the medication and the patient's internal biological environment are aligned, when dietary patterns, sleep, physical activity, and stress are working in the same direction as the medication, outcomes are stable and doses remain manageable. When they are not, doses escalate, not because the medication is failing, but because the system is working against itself in two directions simultaneously. The best outcomes I have observed in 3 decades of practice are never medication alone. They are medication working within an environment that has been deliberately made as compatible with the treatment goal as possible. 9. The truth that is almost never said on the day the prescription is written after 30 plus years and thousands of prescriptions. This is the single most important truth about these 3 medications, and the one that is almost never communicated on the day the bottle is handed over. None of these medications eliminates the condition producing your elevated blood pressure. Amlodipine reduces how tightly your artery walls contract. It does not remove the arterial stiffness that accumulated over decades of biological aging, inflammation, and hemodynamic stress. Lisinopril blocks the enzyme producing the vasoconstricting signal. It does not repair the vascular remodeling that made those signals chronically excessive. Losartan locks the receptor the signal needs to bind to. The signal is still being produced. The underlying biological process generating it continues. All 3 medications manage the downstream output of a system. They do not modify the upstream processes generating that output. This is why monitoring matters more than the initial prescription. This is why lifestyle modifications are not optional additions. They address the upstream processes the medication cannot reach. This is why a controlled number on a blood pressure reading does not mean the biological conversation is complete. The patients I have seen maintain the best long-term outcomes are not the ones on the largest number of medications. They are the ones who understood both what their medication was doing and what it was not doing, and made deliberate choices to address both realities simultaneously. The practical summary. If you take amlodipine, expect ankle swelling that is worse by evening and resolves overnight. Report it. Do not hide it, and do not skip doses to manage the embarrassment. Watch for dizziness on standing. These are predictable mechanical effects, not signs of cardiac deterioration. If you take lisinopril, a dry, persistent cough can appear weeks or months after starting. Report it and understand that a straightforward switch to losartan eliminates it. Any swelling of the lips, tongue, or throat with breathing difficulty is emergency care immediately, not a phone call. If you take losartan or lisinopril, read every label on heart-healthy products in your kitchen for potassium content. Ask your physician whether potassium-based salt substitutes are appropriate for you. Ask when your serum potassium was last measured. For all 3 medications, do not use ibuprofen or naproxen regularly without explicit confirmation from your physician or pharmacist that it is safe given your complete medication list. Call your physician before your next dose if illness has compromised your fluid balance. Measure blood pressure consistently under standardized conditions and respond to patterns, not individual readings. Never discontinue these medications abruptly without medical guidance. The rebound effects can be significant. What happened to Arthur? After Eleanor's call, I adjusted Arthur's amlodipine regimen, reviewed his dietary sodium intake, and sat with him, not with his chart, with him, and explained everything I have just shared with you. He understood for the first time why his ankles were swelling. He understood it had nothing to do with his heart. Within 3 weeks, the edema was manageable, his blood pressure was stable, and Arthur was back at church on Sunday morning. At his follow-up appointment, he told me, "I spent 3 months convinced I was dying of something that had a name and a straightforward answer. I just needed someone to explain it to me. 6 months later, he brought a one-page summary of what he had learned to 23 men in his Sunday group. 5 of them went to their physicians with questions they had never known to ask. 2 had medication adjustments that were long overdue. 1 had been experiencing dizziness on amlodipine for 7 months and had attributed it entirely to getting older. The information existed. The solution existed. The conversation simply had not happened yet. That is the gap this channel exists to close. The seniors who manage their cardiovascular health best are not the ones on the most medications. They are the ones who understand what is actually happening inside their bodies and use that understanding to make better decisions every single day. Arthur did not need a different medication. He needed a conversation. Patricia did not need months of sleepless nights. She needed one question answered. Bernard did not need to stop eating carefully. He needed to know what was already in his kitchen. Information is not supplementary to treatment. In my experience, information is part of the treatment.